Hi, it's Dr. Centeno, and sorry for arriving early. I think I had put on Facebook that I was going to do this at 1:30, but then I belatedly realized that I had a 2 o'clock. So I didn't want to do this for only a half hour, so I'm starting a little bit early to see if we can get a full hour in here, because normally that's kind of how it goes. So today we're going to talk about cervical lordosis or the cervical curve and how that might impact things like CCI or other neck problems. And we're going to do this a little differently. Instead of doing a didactic lecture, I'm going to go to a PowerPoint slide that I have set up where I can move the neck curve around and you can kind of see what's going on with that. So let me go ahead and start that. Again, you can answer or you can ask questions anytime. It doesn't have to be about this topic, can really be about anything at all. And I think I've got some questions that were pre-submitted. So I'll go ahead and I'll start with those first once I get done with this little discussion of cervical lordosis. Again, we're starting a little early today. I think I had put in 1:30 and didn't realize I had a 2 p.m. Hard stop. So I wanted to do this for more than a half hour because that usually creates some problems in trying to get to all the questions if I'm only on here for a half hour. So let's go to the topic, which is how your neck curve or cervical lordosis can affect lots of different things, including CCI. So let me go ahead and start this and just share my screen. Okay, so instead of starting with a didactic lecture, instead we're going to start with just a PowerPoint slide so I can kind of move things around a little bit. So, the topic that we're going to get into today is how can a lost neck curve make CCI and other neck issues worse or better? And to do that, rather than a static didactic lecture, I'm going to use this PowerPoint slide because I can move things around and I think better illustrate the points here. So let's start with a normal cervical lordosis, right? That's what you're seeing. So a normal cervical lordosis is a normal cervical curve. And in that case, we've got the weight of the head pretty well balanced. So the forces are approximately equal in the front and the back. And that's really the goal of that cervical lordosis. It also takes some of the weight from the front area here off the discs, and it distributes that 50-50 into the joints, the facet joints back here. So that's perfect neck curvature. And again, there's a reason for it because it's balancing the forces of the head. Now, if we lose that lordosis, and I'm just going to go like this now, make it straight, there's a couple things we notice, right? The first thing is that really all of our force now is going straight down onto the vertebra. And in fact, there are discs between these vertebrae. And so we've got an awful lot of weight now that's going on to the discs. And so we tend to see people who have lost their normal neck curve, their discs start to go because all of a sudden the weight isn't distributed 50-50 between the front and the discs and the back and the facets. It's overloaded on the disc side. Now let's look at what we see in a good number of CCI patients. I saw one this morning like this, where the neck curve kind of goes backwards. I'm going to move that over there. So in a backwards neck curve, we've got some big problems. And that's the same thing that kind of happens with a lot of this kind of stuff too, poor posture, etc. Thoracic kyphosis down here, leading to a loss of the normal cervical curve or lordosis. Thoracic kyphosis is this kind of hunchback sort of thing that we all get. And so a couple things are happening here. First thing is we still have a lot of weight going on the discs, right? In fact, in the front part of the discs, and we tend to see in these patients some bone spurs develop up in the front here. But we're also now putting some interesting forces with this head because the head kind of wants to slide forward like that. And we have the upper neck ligaments that are stopping that forward slide of the head. So we're overloading the upper neck ligaments here. So overload of upper neck ligaments with loss of cervical lordosis, or loss of that normal neck curve. In fact, we have a reverse curve going on here. So that's not good. Also, all of these ligaments back here are getting overloaded too, including the muscles and ligaments in the back of the neck. And so that's the reason why I'll ask a lot of patients with CCI to try curve restoration, or once we get the upper neck tightened down through something like a PICL procedure, we're asking patients to try to get that curve back, because if we don't, we're just continuing the high forces on those upper neck ligaments. Now, there's something else to show you here, and that has to do with the cervical spinal cord, which was affecting the guy that I had, or that I saw this morning. So assuming we have kind of a normal neck curve here, we've got the spinal cord that lives right behind those neck bones, and there's discs at each level. One of the things we tend to see is when someone loses the normal neck curve and it actually starts to go backwards, you can see it bangs into that spinal cord. And by banging into that spinal cord, that is causing all sorts of problems: numbness and tingling in the hands or feet, weakness in the hands or feet. This particular person had some weakness in the feet, and weakness in the legs. So that's another reason to try to get that curve back, because again, you see curve up here, pulls those discs away from the spinal cord, curve goes back that way, bangs into that spinal cord. So another thing to consider. So sort of in conclusion, this normal lordosis is an important thing, because that normal lordosis allows you to be able to distribute the forces 50% up front, 50% towards the back. And that helps to maintain stability in the upper cervical spine. That helps to balance the forces between the discs and the facet joints. But when you lose that lordosis, or that curve, or it goes backwards, everything changes. So if we lose that lordosis and it starts to go backwards, we can get into situations where the upper neck ligaments now are really starting to struggle, because they're having to actively work just to be able to keep up with all this stuff, this new position. And realize that it's also changing things like clivoaxial angle and grab oaks, etc. So let's just look at clivoaxial angle here, right? So when it comes to clivoaxial angle, and this isn't going to be perfect because I don't have a perfect model drawn here, but I'll make it as good as I can. So clivoaxial angle would be the angle between the clivus there and around C2. So let's say the angle is that. But watch what happens when I change this curve. That angle is going to change wildly with the curve. So when we have these clivoaxial angles and we know what's normal and abnormal, it's based on that normal curve. Once you start changing that curve, all bets are off on that angle. So that's also causing and wreaking havoc with surgical decisions even. So I'm going to start to take some questions, but I wanted to do this little deal with the model so I could show you and kind of get into your head so you can start thinking of what's happening with that lost curve. So let me go and start. I'm going to start with the pre-submitted questions, and then we'll go with the questions that are live. So pre-submitted questions here. Let me stop sharing that there. Diana, when I nod yes, my head zigzags and feels water in loose. Looking down almost seems to move my skull forward. I see Dr. Rose's soon. Will his MRI likely be able to pick up AO joint stuff? Recent supine MRI doesn't comment on abnormalities of the AO joint. Is this dangerous, or is it my head? I'm okay to move my head. Diane, I don't think it's dangerous. I don't think you're going to cause yourself to be a quadriplegic, for example. But you certainly may have some instability. Dr. Rose's MRIs may be able to see in a live, moving fashion what's going on there. So I'm sure he'll go ahead and put together an MRI type movie to see if we can see what's happening there. DMX would also be helpful, as I think we've talked about before. Diana, again, hi, Dr. Centeno. I don't think Regeneric stem cell formula ships to Canada. How can I get access to it? If not, what should I take instead? It's too late to start cutting down my sugar calories now with my treatment in mid-December. It's never too late to start cutting down sugar and calories. When it comes to the Regeneric stem cell support formula, Carla has a list of ingredients. So if you can't get it in Canada, then you can certainly just part out the ingredients. Christine, have you had many patients with EDS? A large number, yeah. I would say right now that a good chunk of my patient population has EDS, and that's probably 1 in 3 of the CCI patients that we see. So a large number of patients. Fatchen, what is the success rate and symptoms improvement of your posterior PRP compared to the 70% of PICL? What ligament or other structure generally directly injected with posterior PRP? Fatchen, we normally don't do posterior PRP in the same patients, but if we're talking about for the same patients, meaning a patient with a lot of atlantoaxial instability who would be a good candidate for PICL, very low success rates, maybe 20, 30% with posterior PRP. And then the structures that are injected, generally we always inject the supraspinous, interspinous ligaments, the atlanto-occipital ligaments on the side here, and any joints that need to be injected. More commonly, that's C0, C1, C1, C2, C2, C3, but sometimes other joints depending on what's happening with that person. Christine, I've lost some curve. What can I do? Because I can't carry weight because I'm too bad for that. If you've got loss of curve, Christine, a good place to start is chiropractic biophysics. So if you go online to www.idealspine.com, that's idealspine.com, and I'm not related to them. I don't get referral fees or anything like that. But that's where you can find providers in your area who have been trained how to do curve restoration. Fatchen, in your scale of CCI functionality with 4 levels, is it possible to jump 1 level up with successful treatment of PICL or posterior PRP? Yeah, generally I think that's pretty reasonable. Patricia, what's worse, loss of curve or poor posture? And please discuss having both. Patricia, they're really related. So people that have, quote, poor posture tend to have a forward head position, loss of cervical lordosis, and increased kyphosis of the thoracic spine. So as you can see, one's part and parcel of the other. Deanna, what are the effects of reverse curve on the vagus nerve? Yeah, Deanna, I do think having a reverse curve can put some pressure on those anterior neck structures there, more so than having a normal curve, because it has the effect of bringing that top part forward into those structures like the vagus nerve, glossopharyngeal nerve, internal jugular vein, etc. Fatchen, can loss of neck curve be associated with multifidus muscle atrophy? Should this be a signal of possible instability, even if spine MRI measurements were the normal limits? We certainly see multifidus atrophy in patients with loss of neck curve. Whether they're related, I don't think anyone knows at this point from a research standpoint, but interesting concept. Okay, let's go to some live questions here. Liam, on DMX, my ADI looks normal, but symptoms may suggest different. Looking down, inflection flares up my head pain, and occipital muscle spasm a lot, plus gives me dizziness. Could my guarding cervical muscles be massing an abnormal ADI and associated damage transverse? Yeah, we have seen that, Liam. So normally what happens is that when we put the patient asleep for something like a PICL procedure, Because we're lying face up in a little bit of neck flexion, we will see the ADI open once we have them asleep. And we've seen that lots of times. In fact, I just saw it this week. Now sometimes that's because we see it open on the DMX, and sometimes it's totally stone cold normal on the DMX. So I think what you're saying is certainly possible. And the way to find out would be to put you to sleep lying in flexion face up and see if it opens up. Obviously, if we're doing a PICL anyway, we can just report that back. Liam, can brainstem compression occur with damaged transverse but no retroflex odontoid? Certainly, realize that you've got the dens, right? And the transverse ligament is the seatbelt for the dens. And right behind the dens is that spinal cord. So if there's extra motion of the dens backwards towards the spinal cord when you flex, that can certainly cause some intermittent brainstem compression. What are your thoughts on CCI being a leading contributor to the loss of cervical lordosis? My neck is very straight, and I feel like it may have become straighter since CCI onset due to the extreme muscle guarding. I don't believe my neck was always this straight, but could that be bad posture of the years that caused it? Well, certainly there's a lot of patients who have CCI and who have loss of cervical lordosis. Having said that, for every one of those patients, there's probably 100 or more out there who have loss of cervical lordosis and no CCI. So it'd be hard to draw that conclusion that one causes the other, but I can certainly say that one's not helping the other. WJH, what is the best way to correct the neck when you have bone spurs? The pressure from neck rolls and traction, dental roll, cause more symptoms of the pinching pressure placed on the nerve. Yeah, so that's a really good question. And the answer may be that curve restoration is not a good fit for you. I've certainly seen patients where there's just not enough room because of bone spurs in the central canal to allow good curve restoration to occur. So that may mean that, the best you can do is to stabilize the ligaments in the back of your neck. And you're not really going to be able to solve that problem of the curve. WJH, how do you feel about foraminotomy for bone spurs along with regenerative treatments? The biggest problem with foraminotomy is that it's destructive, right? We're destroying normal tissue and we're damaging normal tissue to get in there. So the answer is regenerative stuff without surgery should always be tried first because it's frequently successful, even when a patient has been told they need a foraminotomy. And then if that's not successful, then you go up the ladder of invasiveness and do a foraminotomy and maybe add regenerative treatments on top of it. But out of the gate, I see very few patients that need foraminotomy out of the gate. Simply because, we see patients who have been told they need foraminotomy, we treat them with regenerative medicine, they never get the foraminotomy. So that's the place to start. But then obviously if that doesn't work, then you can do that plan B. Diana, curve restoration therapy looks so scary with the traction from the videos online. Can it make CCI worse before a PICL? Yeah, Diana, I think the best thing to do is, as I always say, to do a home test. And that home test is to take a towel, roll it up. Now you may have to experiment with making it thinner or thicker, and place it behind your neck and lie face up on a bed. And if that feels good and doesn't really cause a big flare up in your symptoms, then I would give curve restoration a shot. If, however, you wouldn't be able to tolerate something like that, you're probably not going to tolerate curve restoration, and I wouldn't go there then. So I always tell people to do that home test first and see how they kind of filter themselves out. Because we certainly do have CCI patients where their instability is too bad to do curve restoration. We've got to tighten things down before they can do that. So I think your overall sense that it might make it worse is reasonable, and you can kind of try that at home. Christine, I stretched my neck, made a very bad movement. And after that, I got stiff. Have you had patients with EDS where they stretched their ligaments and got stiff and got a lot of bad symptoms and treated them well? So certainly stiffness or muscle spasm is often there as the body's response to instability. So when you stretch your neck and it gets stiff, it means that something moved or something got injured that wasn't supposed to move or get injured. And the body's response was to protect that by increasing muscle tightness. So that's pretty normal, and that's a normal response to instability. Diana, AO has helped bring my rotation from 6 or down to 6 from 12 degrees with local AO. Lots of worsening of bobblehead and nodding, worse and choking sensation. This is why I'm trying ROSA. But is it wise to keep trying AO? It's promising I'm reducing rotation, but it's tough during the process. Yeah, listen, Dr. Rosa is a super expert on all of those things AO. So I think that's a great move to see him. He can then maybe even give your AO another vector or another approach to use to see if you can maximize treatment. I've seen him do that for a lot of patients through the years, and it's pretty magical when he's able to do it. Diana, I had my consult with you, and you mentioned a large osteophyte on my atlas. Could this bone spur be somehow be involved with my nodding issues? Can a bone spur prevent the atlas from being put back into place? Certainly could. It could cause all sorts of problems. Realize that bone spurs form because of instability. It's the body's way to try to stabilize the area. But it certainly can limit then range of motion. So in particular, range of motion in the C0, C1 joint. Edward, what's the normal limit for EDI? So that's atletodental interspace, or the amount of space between the dens and the atlas. So C1, C2 up front. In the CCI 101 book, it says 2 millimeters, while in your YouTube videos, they state 1 to 3. I've even had some practitioners tell me 4 can be normal in younger people in their late teens, or the range dependent on imaging modality, for instance, CT versus plain X-ray. You know, normally the number that's used is 2. But like anything else, the higher you make that cutoff, the more likely it is that you're seeing something that's abnormal and causing symptoms versus not. So a good example would be what we often talk about with C1, C2 overhang with lateral bending or open mouth lateral bending. We can use 3 as the abnormal cutoff, but based on the Katz et al. Study, that means that we'll have about a third of the patients who will misclassify as that being abnormal. If we use 4, that misclassification goes down to only 1 in 20 or 5%. So if you're seeing various numbers, I think what you're seeing is that there isn't a cutoff for many of these measurements. As they get higher or farther out of normal, it's more likely that what we're seeing is an abnormality. If we use the lower cutoffs for all of these, then we just see a higher rate of misclassifying someone as having a problem when they really don't have a problem. Regenics, mid-advanced by Deanna Clara. I think I got that one already. Edward, is whether or not someone has a honeymoon period indicative of how well someone will respond to PIC on the long term? Yeah, that's a good question, Edward. I don't know the answer to that one, and that's one we haven't looked at formally yet. My overall sense is I like to see it. It makes me feel warm and fuzzy that we're headed in the right direction, but I don't know that it's related to overall outcome. And when I say it makes me feel warm and fuzzy, it allows me to say, okay, if we just tighten down that area, like is present during that honeymoon period, and there's some natural inflammation, that then can probably lead to a successful treatment. But whether or not it's related to overall outcome, I don't know. Regenics, yeah, got that one already. I think I got all of these already. So I'm going to skip those. Deanna, will Dr. Rosa's extension flexion MRI be able to calculate an ADI? Sure, should be able to calculate an ADI, yes. Now, sometimes on X-ray, it's a little easier to calculate because you can more easily see where the bone starts. And sometimes you got to play around with the MRI imaging to make sure you know where the bone starts. Because sometimes, for instance, the bone can get lost in a pannus, for example. And you look at another MRI image and you see that definition between the bone and the pannus, but on certain MRI images, they tend to fuse together and it looks like they're not the same, that they're the same structure. Christine, what is the success rate? Have you had many who got worse or didn't see improvement? Success rate for, I think what we're talking here would be glenoaxial instability with abnormal overhang is about 70%. As far as number who got permanently worse, that'd be a very small number. And as far as don't see improvement, that's about 30%, or at least enough improvement to warrant to say that they're not going to do anything else. Edward, if ligaments have a blood supply, albeit not a large amount, and ligaments are injected with BMC, does that mean that some of the stem cells make their way into the bloodstream? Would it be potentially harmful? Ligaments have a smaller blood supply, but don't have a great one. And we know that because under X-ray guidance, we put in contrast into these ligaments, and it's still there a long time afterwards. So there's not much outflow from ligaments with regard to injecting something into the ligament. So again, we can see that happening on X-ray guidance. And the cells obviously would be larger than the little particles in contrast. Those little particles in contrast are going to be much less than 1 nanometer, probably a fraction of a nanometer versus, a mesenchymal stem cell is about 13 nanometers. Deanna, I like reading a variety of successful testimonials as replacing the website with more CCI testimonials. I've only seen Pam's, another Canadian rancher, I believe. Yeah, we've got a lot of them for sure. And I can certainly work on getting more together. I think a lot of it is just time-based, but what you can certainly do is to reach out to Carla, my assistant, and I'll put her email address here because she's a key person in all of this. So I'm putting here the email that goes directly to her desk. So I'm just putting it in the comments for everyone if you don't have that. But what Carla can do is to certainly link you up with people who are willing to talk about their experiences. Realize that that's not a perfect system, right? We have to have someone that does well and then someone who says, sure, have someone call me, no problem. Some people don't want to be bothered in doing that. Some people are very passionate about doing that. But you're right. I can certainly get together more testimonials than I have. Just too many balls in the air. Christine, and do we know why they don't see improvement? Is it because they don't have real CCI or question mark? I would think they would probably fall into 2 big categories. Well, let's say 3. One category would certainly be that the CCI is too much, or there's been too much ligament damage for an injection-based procedure to solve the issue. Another category would be that there's been permanent damage to the neural structures because this has gone on too long and there's just no way to fix that permanent damage. And then the third would be they never had CCI to begin with, causing symptoms. And we try as hard as we can to reduce that false diagnosis rate. And as many people know, we've turned lots of people away, but it's not zero. There is no blood test I can run that says you definitely have CCI or you don't. So we try as hard as we can to reduce that one. But those are the 3 things that come to mind. Braun, how many cells do you inject in a single cervical or lumbar facet with Regenix C? A good number. Usually it's about 1 million mesenchymal stem cells, somewhere in that range. Bethany Cobb Jones, hi Dr. Centeno. I'm coming to see you on November 30th with my first PL seal. But I would also have lots of lordotic or loss of lordotic curve, possible starting kyphosis, and severe disc bulge at C5-6. Will these factors affect the success of the PICL? Also, I put off getting disc replacement in 5-6 because you said that would just make the CCI worse. Having said that, what can be done to help the 5-6 disc bulge or assist healing? Yeah, normally we'll treat all of those things at the same time, Bethany. So we'll treat the 5-6 area. At the same time, we're treating the lordosis by tightening up those posterior ligaments. At the same time, we're treating the PICL. So normally we're treating all of that at the same time. Diana, thank you. I see Dr. Rose, and then send all of my MRIs to Carla for your review before my procedures. Is this okay? Because if you can see what you need, might not need the DMX. However, I do have an osteophyte, which you need to see the width of, so perhaps this isn't seen on MRI. Yeah, the best way to see the width of that osteophyte is generally, regrettably, a CT scan. Even if we do a limited CT scan through the area. Now, it's also possible just to say we're pretty sure we can get in and realize that it may be possible we can't, or we can do a limited CT scan in the area because that tends to show the bone relationships a little better than MRI does. But certainly, I think starting with Dr. Rosa, then getting us those films is a great idea. I mean, Dr. Rosa is an international super expert in all of this stuff. Chad, hi, Dr. Centeno. I currently have a malrotated C2 that has been sticking out to the right for many months. Is this indicative of lax ligaments, or more likely just muscle guarding pulling out to that side? You know, as far as it sticking out, if it continues to be malrotated, and we know that that's the case, then there could be an instability component. Also realize that that can happen with scoliosis. So we saw a new CCI patient this morning, but fairly substantial scoliosis. And so that's putting differential forces causing rotation in the upper cervical spine. So make sure there's also not a side bending or scoliosis component lower down. And it also could be due to muscle guarding, a chronically tight muscle in that area. So maybe it's not sticking out as much as it is just chronically in spasm. But I think, a good idea would be getting something like a DMX where you can see how all of that is moving. Christine, how can stem cells help on the stretched ligaments I got? Yeah, Christine, the goal is to get the ligaments to heal, whether that be with prolotherapy, platelets, or bone marrow concentrate. But the goal is to get the ligament to heal. Chad, symptoms include lightheadedness, foggy something, and nausea. Could this be caused by pressure on the vagus nerve or something similar? So I'm assuming you're saying head fog, nausea, lightheadedness. So it could be the most common things in that differential. I mean, one of the things, because the lightheadedness and the nausea would be the upper neck. So upper neck joints. Another thing in the differential could be a vestibular problem if there's a dizziness or imbalance component. If not, then not. As far as pressure on the vagus nerve, that wouldn't be a leading cause for lightheadedness and nausea. Edward, do we know if there are genetic factors at play which determine whether someone responds poorly well or very well to orthobiologics? Is there any way to test this beforehand, or are we just not there yet? Yeah, not there yet, but that's really great stuff. And I think that we'll see that at some point. For instance, we do know that there's a certain mix of chemicals within the knee that are associated with a better bone marrow concentrate procedure outcome for knee arthritis. Now, that's dialing in from one direction, that's called the microenvironment, but it may be possible to dial it in from a genetic side as well. My guess is they'll probably always have to be looking at both. So it's not only your genetics, but also, the environment which these cells are going into. And then obviously how good or bad the cells are to begin with. Christine, can you see on MRI how much damage there are on ligaments? You can, and you can get an idea. The ultimate way to see how much damage there is in ligaments is a movement-based study. That way you can see if there's excess motion that the damaged ligaments are allowing. So that's the prime way to do it. but you can get a sense of whether or not the ligament looks normal on MRI as well. Bethy, do you recommend seeing Dr. Rosa after having PICL for adjustments, or should the tightening of PICL ligaments help pull the C1, C2 in place? If you already have an existing relationship with Dr. Rosa and he's convenient, then great. I would see him after, because if someone is seeing an AO chiropractor before, we always recommend that they do that after to keep everything in place. Now, I don't know if Dr. Rosa is down the street or convenient, or if there's someone else who's closer, but seeing someone to keep things in place is a good thing. Diana, my symptoms scare me, especially when my head feels like it will fall off. I'm trying to calm my mind, but at what point does CCI actually become dangerous? Do you look at a large ADI to make this determination? Yeah, Diana, that's why a DMX is really helpful. I have certainly seen a handful of patients through the years who have a big enough ADI where you could really warrant saying emergency surgery is an option. And none of them ended up getting emergency surgery, and we ended up fixing them through orthobiologics, but they were definitely in that category, and they were sent promptly to a neurosurgeon who said, nah, I think we're good. So that DMX is very helpful to see if that ADI is getting large. But there we're talking about an ADI of 5, 6, 7, 8 millimeters, not 1 or 2 or 3. Giovanni, how long after receiving treatment, PRP or stem cells, should you wait before doing curve correction? Yeah, Giovanni, no, it's a good question. Really, curve correction, if you got the PICL procedure, should wait until you get a thumbs up from your doctor. Now, generally, that's going to be at least a couple months later. Now, if it's just routine PRP in the back of the neck, and we're just doing the supraspinous, cerebrospinous ligaments, there is no real limit there. The limit becomes when it's comfortable to do. Christine, is there specific symptoms you can say that are related to too much ligament damage? Because I'm scared if I have too much, or it's different from case to case. It all depends on what ligament we're talking about. If we're talking about craniocervical instability, those symptoms, as an example, would be headache, vertigo imbalance, upper neck pain, those sorts of things. It looks like we got spammed here. Find your love in U City. So I don't know who that is. So I'm going to skip those. Christine, Southside. I really want to come to your place, and I'm from, I don't have where you're from. But, listen, Christine, Carla would be the person to reach out to. I had put her email in the comments. So go ahead, if you could, and take a look at those and try to see if you can reach out directly to her, because she can help facilitate that. Giovanna, you mentioned that you should see an AO chiropractor receiving treatment, but I was told by Dr. Schultz to wait 2 months. Wouldn't it be in place a lot of ligaments to heal easier? Yeah, so if someone, what you may have heard is that if you don't have an existing AO relationship, we're going to want things to heal. But if you've got existing AO relationship and you're getting temporary relief, I put no restriction on whether or not somebody can go, the next day even. In fact, we just had a patient do that. I think she got out of place when we were during the procedure, and she was in a lot of pain because of that, and then went to an AO the next day and felt better. Levon, hi, Dr. Centeno. Hello. Christine, I really want to go replace, but I'm from the EU and USA, I need a vaccination, but I can't tolerate vaccination. Is there any way I can get a solution, maybe? So as far as that goes, I don't know what's happening with vaccination and entry to the US at this point. Not up on that one, so I can't answer that question directly as to whether or not you absolutely require a vaccination to get into the US at this point. I thought you didn't. I thought they had changed that, but I'm not 100% sure. Edward, what percentage of asymptomatic people walking around on the street have a loss of cervical lordosis? Yeah, good number. But realize that it's a little bit like um, many things where it's leading to increased overload, which then leads to bigger problems. So I think that would be a high number, especially today, and especially amongst younger people who, well, a lot of us do it, do this all day. Having said that, we know going the other way through multiple peer-reviewed studies that if we increase the curve, we can improve the pain. So for those people who have become symptomatic, we can go the other direction. Deanna, when I see you for my treatment, is your physical exam quite thorough? Does it impact treatment? Oh yeah. I mean, treatment is really determined based on that physical exam, meaning that we've got a bunch of different things we will add or subtract based on what's on that physical exam. And realize that many times we're getting in and looking at lots of different things, so everything from the neck to the shoulder, to the upper back, to the lower back, to the knee, to the ankle. I mean, we've done it all in various CCI patients, depending on whether or not they could tolerate it all. Elvis, do you know something that can moderate nausea? I have it since 21 years, and it was my first symptom after car accident, and now really bad, can't find anything that's helped, new glasses. Yeah, can CCI cause nausea? It can, as can upper cervical injuries. So injuries to the upper cervical neck joints, C23, C12, C0, C1. As far as can moderate nausea, THC is a powerful one for moderating nausea. I'm not sure if you've tried that. You probably have these days, but that's a powerful one for moderating nausea. Obviously, the other is trying to figure out what's causing it. Levon, does age impact success of curve restoration? Yeah, Levon, I certainly think that for those patients who have a lot of bone spurs and changes in shape of the bone, they're going to be less likely to respond to something like curve restoration. So I do think that that does play a role, as I had mentioned in someone who had commented above. So I do think that plays a role. Deanna, when we arrive in Colorado, can we ask your staff to wear a mask? I'm so terrified of COVID with this instability. Yeah, Deanna, there's really no medical reason for anyone to be wearing a mask right now. So no, we generally won't do that. We've got staff that are all vaxxed, et cetera. You got to be to work there. Kevin, regarding your prior point about how long to wait after injections for an AO Atlas adjustment, does that also apply to standard posterior prolotherapy injections as well? Yes. Christine, you said that neck pain and upper cervical pain and balance vertigo could be severe, or maybe could be due to ligament damage. I don't have pain, but I'm dizzy, balance problems. Yeah, so the first thing obviously is an ENT workup for balance problems and dizziness, trying to make sure it's not inner ear related. After that, obviously things like an MRI of the brain to make sure it's not due to a brain tumor or a mass, something like that. And if those things are ruled out, then the next most common thing would be the upper neck. So upper neck can cause those things as well. Megan, if symptoms caused me to be mostly bedbound for a couple of months by trying to push through, but I'm now able to upright most of the day with a hard cervical collar, would you expect a flare from PRP or PICL to make me bedbound again for a while? Probably not, but a lot of that would depend on how you respond to these kinds of treatments. So if you've had prior neck injections, your response there is very educates us, a lot. Another thing would be how you respond to hands-on treatment. So for example, does massage feel good or not really make a difference, or does it cause you to flare up for a week? If you're in the camp where a massage caused you to flare up for a week, then you may well have a much harder recovery. That's what we call central sensitization, or I think I've also called it the fragile egg here. Giovanni, for fixing my curve, I fixed my work setup so I have my monitor slightly above my eye level with the idea of fixing the curve. I saw one of your articles saying to put them at or below, which is the best. I think you want it level with your eyes like this, but then realize you also probably want a low back support to help promote that curve. You got to look at the seat to make sure it's not pushing you forward. So all of those things might help support the curve. I don't know if they're going to get rid of a lost curve, but they're all very good ideas to help you manage that. And then, doing stretches to open up the chest. I think I've got a Swiss ball super stretch that I put online maybe, I don't know, a couple months ago that you might want to look up on the Regenix site, that kind of stuff. Amy, I PRP 1 year ago. I'm doing pretty well unless I've done too much. I get another MRI to evaluate my progress. Yeah, Amy, it just depends on what we're looking at. Maybe if you can put what your main issues are, I can tell you whether another MRI makes sense. Chad, I've had lots of lower cervical degeneration, and as I mentioned earlier, a C2 malrotation. I've had a cervical MRI CT scan, and the neurosurgeon says not a candidate. Would you recommend DMX prior to? Yeah, certainly sounds like DMX would be a good next step. Consulting with your practice, yes. Deanna, have you seen patients' bobblehead get worse from posterior PRP in C0 to C2? Not that I can recall. Certainly, again, if we're talking about the fragile egg scenario, where so this is how I described it to my patient this morning. This is a guy who had had 6 prolotherapy visits in his neck, helped him some, but he was still having a lot of problems. So as I described it to him, tell me about how you responded to those neck prolotherapy injections. He had said the first one gave him 5 or 6 days of stiffness, and then now he gets 1 or 2 days after the procedure. And as I described to him, I said, okay, well, that's great. You're not in the fragile egg category, because if you were, a single prolotherapy visit might set you back a month. So if you're in that category, anything's possible, but no, not the normal patient. Christine, I have CCI and balance problems, tingling in the whole body, dizzy, heavy head, pressure, swallow problems, etc. I will just hear if these are symptoms you have treated before, or does it sound too severe for you because I really want to fight to come to USA without vaccination? So yeah, Christine, we would want to do a telemedicine visit first so that we can look at your CCI diagnosis and make sure that we agree with that, and then try to make sure that we see enough imaging evidence to warrant you coming out here. So those would be the steps. Chad, other symptoms are clicking, clunking when I move my neck in certain ways. Yeah, Chad, those are generally instability signs, whether it's degenerative instability, which is more common, or something like craniocervical instability, which is less common. That's where that DMX comes in handy. Okay, guys, so I'm going to take maybe 5 minutes more of questions, and then I've got a 2 o'clock, so I've got to jump off. Amy, thank you. I'm still stinging C6-7, or I still get stinging C6-7, sorry. I'm usually stiff and turning. I have severe bilateral facet arthritis, really improved since Dr. Torrance performed my injections. Yeah, I would definitely go back to Dr. Torrance then and see what he thinks, but in all likelihood, probably another procedure. Rigoleb, would PRP BMC injections be useful also in the muscles like the scalenes, SCM, the suprahyoids? They can be. It just depends on what it is we're trying to accomplish there. The good news is that the hematopoietic stem cells and bone marrow concentrate can substitute for the muscle satellite cells, which are muscle repair cells. So that's not a bad idea. It just depends on what we're treating and why. Kevin, what have you seen to be the most successful in terms of curve correction? Would that be chiropractic weights that go in the head or around the neck, a firm roller used by the neck while laying down the ground, or something else? Yeah, the single most effective thing is not the weights at all. I've seen one clinic in particular try to use a lot of weights, and it's usually not helpful. The single biggest thing I've seen is actually going to a curve restoration specialist. You can go to idealspine.com to find those qualified doctors, and they've got specialized machinery in the office that they can help you use, and sometimes some things that you can take home. But the chiropractic weights I would put in the lowest success category based on what I've seen. Giovanni, how often do people make full recoveries from injury-induced CCI? About 70%. Now, full recovery depends on where you started, right? I always tell patients, if we're talking about a relatively high-functioning patient, full recoveries are common. If we're talking about an extremely low-functioning patient that has been in bed for 5 years, getting them back to marathon running is probably never going to happen regardless of what it is they do. Edward, you've mentioned that you've seen interesting things with Kat's office where improving one cervical lordosis improved their overhangs. Were these people getting CBP within the first few months, which is why they saw the improvements? Yeah, generally, I think we've seen improvements in their DMX when they're getting good CBP, because it's taking weight off those ligaments. And if it's a relatively recent injury to the upper neck ligaments and it's been caught early, that may allow enough healing and reduce force there enough to allow this thing to finally get better and tighten down on its own. Deanna, why do Canadian neurosurgeons deny so many patients a fusion when they have severe CCI? I've heard these stories. Yeah, Diana, I think you have to realize that, I think as I've always said, there's probably 70% of all of the CCI surgery in the United States and really worldwide is done maybe by a handful of surgeons, 6, 7, 8 max. So this is a super duper specialty area. So the likelihood you're going to randomly walk in on one of those 6 neurosurgeons around the world is pretty small. So it's like anything else, you've got to find the folks that have a lot of expertise. Christine, I've already scheduled a consultation over video, but still just wanted to hear if they sound familiar in some of the symptoms: stiff neck, balance, dizzy, heavy head pressure. Yeah, all of those certainly sound along the list of things that can be associated with CCI. Levon, if legs arm weakness is due to spinal cord being banged on, yet there is no physical damage to the spinal cord in MRI, does that mean that once you resolve instability and stop banging, symptoms resolve? Generally, yes. What are your thoughts on CD57 count in Lyme and being a PRP candidate? I'm not a big, I think as I've told you guys before, not a big believer in chronic Lyme. So probably not even going to go there with a comment on that. Realize that chronic Lyme is not something that's recognized in the peer-reviewed medical literature. It's not something that's recognized by the traditional medical community. And while there are many things and concepts I work with every day that would be considered integrative or alternative, I don't get into it that far. As far as being a PRP candidate, we've certainly treated lots and lots of patients who have told me they have chronic Lyme without any issue, but not a big believer in the concept. Chris, and I received pelvis injections of my pelvis ring, but I've been feeling much more severe symptoms at 2 months out. I can't hold my adjustments there for more than a day. It's really hurting my C1 alignment. As the day it holds, everything pops back in. Will these tighten together eventually? Will it hold back my PICL healing? Also having problems in my upper thoracic where things are getting stuck. These were not injected. So you receive injections in the pelvic ring. Kristen, I'd have to know more. Perhaps there's severe SI joint instability, and that needs to be treated more aggressively. Perhaps it's due to lifting all the time and it popping out. I'm not quite sure. I'd need to know a lot more. So reach out to me on that one via email. And we keep getting these things on here. Sorry about that, guys. I don't know if there's a setting we can tweak in Facebook to prevent getting the free girls in U City, but it would be a good idea. Regolith, the insertions of the muscles, the tendons on both of the clavicle, first rib, and upper neck insertion points are very stiff and grinding. They seem like they have little rocks and make cracking noise. Yeah, those are all good things to check out. So, for instance, we see a lot of sternoclavicular instability in CCI patients. Giovanni, is it okay to send an email with questions, even though Dr. Schultz was my doctor? Sure, Giovanni, that sounds fine. Joanna, thank you. Okay, guys, so we're at about time. I've got to stop. Again, thank you for spending time with me today. I hope I answered a bunch of questions here. And we were talking about loss of cervical lordosis and how that can affect your CCI and other neck problems. So I should be able to do this coming Monday as well. I'm not 100% sure of the time yet, but I will try to get this done on Monday. And that's generally around 1 p.m. Mountain Time. So thanks so much for watching, and have a great day.